A lively discussion by our panel moderation by Vijay. We come to the next phase for the head and neck cancer. The topic is concurrent chemoradiation. And Vijay has moved out and along with he has taken a lot of people along with him for a tea, coffee or this thing. Anyway, so really I enjoyed the discussion and probably I echo this thing what Amish said that probably last 7-8 years, the medical oncology team led by Vijay and the Kumar Prabhas is doing such a great work for head and neck oncology. I really acknowledge that and that goes from my heart. So basically, discussion point here is concurrent chemoradiation. So basically, these are the points which will be, anyway, it doesn't get, we'll be discussing whether it's a preferred option, yes or no. What is the choice of this thing, chemotherapy, scheduling, dosing, option for non-DDP eligible subjects. And most of the time, probably, like he said, now we have enough data from our own country from various centers. So probably instead of quoting the centers which have been doing studies which have been conducted outside, I probably will be stressing more on our local or Indian data, this thing. So the first point first, whether this is and I'm not going to in individual studies except those which have been conducted in the country. So based on the various evidences, meta-analysis, various trials and this thing, we clearly understand that the concurrent chemoradiation is standard of the care for the definitive, either the non-surgical or high-risk post-operative care. So these are the post-op studies. This is the probably neoadjuvant, neoadjuvant and concurrent versus single agent, single modality radiation. And then we have the meta-analysis 2009 before that, and now latest being 2021, which says that probably it may be an option. It's a preferred option. So coming to there's a last meta-analysis which was published in 2021, and you see a couple of Indian authors also, Sarbani is there, Shalini is there, and so on. So it is really gives a lot of feeling. So what are the basic questions? Close to 20,000 patients. The main question was whether if you add chemotherapy to local regional treatment, which is of course radiation, probably do you get any benefit or not? And if you see that this thing, the bottom line, it says that there was interaction between treatment effect on OS and timing of chemotherapy was significant. The benefit being limited to concurrent chemotherapy, and the benefit was 6.5 at 5 years and 3.6% at 10 years. So this clearly reiterate and again keep on stressing that the concurrent chemoradiation is the preferred modality. That is number one. The same in the chart, probably at 5 years, 6.5% at this thing. Again, there are some probably another few other messages from this meta-analysis. Number one, you need to, if you have the good performance status, definitely you get the better response and better survival advantage. And more importantly, that as the age increases, the benefit of you keep on losing the benefit of concurrent chemoradiation. It's not hard and fast. In our routine clinical practice, usually we do not exceed beyond 70, but this is case to case basis. It's not that you cannot use it. That is the message. So second option is the second question or the discussion is the choice of chemotherapy. There are various options available in the literature. You can use single agent DDP, you can use carboplatin 5-FU, you can use hydroxyurea, you can use EGFR inhibitor will be coming in a while, and you can also use taxane. So these are the various options available. Coming to this thing, if you see, most of us do quote when needed NCCN guidelines. If you see, this is probably I taken a prototype. It's not that we don't use in the oropharyngeal, hypopharyngeal or laryngeal tumor. Basically, I just taken P16 negative as a prototype, and you see this concurrent chemotherapy is one of the listed option. Stage 3, stage 4, and node positive also. That is number message. So what are the preferred protocols or chemotherapy protocols regimens which NCCN suggests? Level 1 evidence, you have for the high dose cisplatin. You have based on the European study, you do have the evidence for the infusional 5-FU and carboplatin. And also recommendation being 2A weekly cisplatin and other agent and this thing. So these are the options which are available, choice of the chemotherapy. So usually we prefer single agent because instead of using infusional 5-FN, this thing, if you are getting the same based on the meta-analysis, probably it did not compare different this thing, but cisplatin single agent is or platinum-based chemotherapy, this thing. I would like your attention. Basically, it's what are the issues with the 3-weekly? Everybody does that. 3-weekly protocol came into practice when they compared the chemotherapy 3-weekly with the single modality, that is radiation. When it started practice, it did not compare with the different dosing schedule of the cisplatin, either the weekly or daily. We start with the ulcer-rafis study in 1990 for nasopharyngeal cancer. Thereafter, we have few oropharyngeal study, and it got popularized after the RTOG and URTC in the adjuvant setting. So they did not compare two different schedule or doses of the cisplatin. They just compared 3-weekly schedule with the radiation alone. So that is the important point. And so there are different options, daily, weekly, 3-weekly. Let us dissect that. This was our own work in 2010. We started in 2003. This was a small study, phase 2 trial, 153 subjects. And we did show that probably you get better responses, better survival. This include oropharyngeal and nasopharyngeal. Nasopharyngeal we included based on the ulcer-raf study. Then came one of the landmark study which compared two different dosing schedule of the cisplatin. Weekly versus 3-weekly, published in 2017, presented 2016, I believe. And so there are certain take-home messages from this study. I'm sure this has been discussed in the scientific meetings more than a number of times. ECOG 0 to 1. And they say non-inferiority study with the non-inferiority margin of 15%. And their primary endpoint was 2-year locorenal control. And they chose 30 milligram per meter square and compared it with the 100 milligram per meter square. So messages from this particular study: completion of planned treatment and more than 2 doses of this thing 3-weekly and more than 6 cycles was completed in 94% in the 100 milligram arm and 89% in the 30 milligrams. So large majority of patients were able to complete whatever was the planned treatment. With median follow-up of 22 months, they could not prove that this is weekly cisplatin is non-inferior to this thing. So ultimately, it was proven that the weekly 30 milligram per meter square, I'm not saying weekly, I'll use word 30 milligram per meter square is inferior to 100 milligram per meter square. That was the message from this particular study. You can see the 2-year locorenal curve wide separating, and there was significant this thing. However, there were no significant difference in the overall survival between the two arms. And authors, Vanita and others colleagues, they also concluded the results of this trial should be interpreted in the context of the type of patient recruited. More than 90% of their subjects were the post-operative patient rather than the definitive setting. And more than 85% of subjects had the oral cavity primary, and they were underrepresentation or they were underrepresentation of the other head and neck primary. And like I said, this thing, and 99% of their subjects were more than almost all patients were ECOG 0 and 1, which may not be possible in many government or public sector hospital in routine clinical practice. It may be true for the private or corporate hospitals or centers, but in the clinical practice, when we do this thing, so we do not see. So this trial, 30 milligram versus 100 milligram, confirm that the 30 milligram, in case you want to use the weekly dose, 30 milligram is not the right dose. Then this was the Japanese data I'm showing because this was again 40 milligram versus 100 milligram. This again was in the adjuvant setting. This again was a non-inferior trial, and they haven't proven that probably this thing. Weekly cisplatin is non-inferior to 3 weekly cisplatin for patients with post-op high risk locally advanced squamous cell carcinoma. So this trial again led down and again ignited the interest in this particular topic, that the weekly versus 3 weekly. And in fact, you can see the survival with the weekly arm was the superior compared to the 3 weekly. Again, our work, probably this is Indian data, which was presented last year ESCO, and hopefully next couple of weeks to few months, probably this is under review. You will see that this get published some in the reasonably good journal. So we chose 40 milligram per meter square. Our hypothesis was it is non-inferior to 3 weekly. Instead of 15% non-inferior margin, we kept it 10% non-inferior margin. And certain differences with the TMH study and other studies, we chose ECOG 0, 1, and 2 patient. And this probably we can skip in the interest of. Like TMH study, we kept 2-year locoregional control as a primary endpoint. I do not need to go into this thing. And like TMH study and many of the public sector hospital in the country, large number of patients, we use the 2D modality for radiation delivery. Unlike this thing conformal or the MRT or this thing, which probably the routine practice in the most of the corporate or private sectors. So I'll come to this thing, and before recruitment, we decided that anybody receiving more than 60 GY of the radiation and 200 milligram per meter square of the cisplatin will be considered to have adequate dose. I don't want you to go into the details. Only thing that to recruit 262 to 72 subjects, we have to screen 672 patients. And this here again confirmed that, probably it's next slide. So the number of patients were, I think, in the 2/3 of patients in the 4th to 7th decade. 20% of subjects had in both the arm had the ECOG performance status of 2. So really we did recruit the subjects in both the arms who had the performance status of 2. Close to 90% were able to receive more than 60 GY of radiation. More than 90% of in both the arm together. And really that was the point I wanted to highlight. About 3/4 of subjects received the radiation treatment through the cobalt, which is I think the fact of life in this country, at least for now. Somewhat similar to this thing, radiation, probably 3/4 of subjects receive more than 200 milligram per meter square radiation chemotherapy in both the arm. So this was the proportion method used for the calculation of 2-year locoregional control. So it falls within our pre-designed margin of non-inferiority 10%. So we said that probably this is non-inferiority. The follow-up is short, just 2 years. And you can see the basically 2-year locoregional control, 57% versus 60%. And the median overall survival more equal. And we also did analysis using restricting this thing to the restricted mean survival time, and there was no significant difference. So these are the survival curves. No, actually, there's no significant this thing. I'm coming to, I'll take 1 or 2 minutes for the toxicity, which is an important aspect of this thing. We did have, usually in the previous publication, we get about close to 10% of the grade 3 or 4 toxicity, whether this is anemia, thrombocytopenia, or neutropenia. There was doubling of the grade 3 and 4. These all are the grade 3, 4 toxicity in this thing. Standard arm versus the control. We did get number of patients having some the renal issues, vomiting, and like Dr. Patil was talking about this thing, hyponatremia is really a significant problem. Only thing is that in clinical practice, in a clinical trial, you monitor them very carefully. The numbers, 1/3 of the patient had the hyponatremia and 20% in the test arm also had hyponatremia. So I don't want to, another point is that many times you get the deaths which are unrelated. That's because of COVID also. I don't want to. So this is just a comparison of 3 studies, TMS study, Japanese study and a study use this thing. And this thing. I just take 1 more minute. I don't want to. Okay, sorry. So another, at least to awake the people who are sleeping. Temple. So number of patients who are presented to us probably everywhere this thing, they are not eligible for cisplatin for various reasons. And I would like to spend 2 minutes over there. So this was EGFR inhibited bonus trial. Everybody knows about that. It showed that the radiation and cetuximab combination is superior to radiation alone. There is nothing new. This has been studied number of times. This has been discussed number of times. What I again would like to discuss and complement, there are two studies from TMH. One was the EGFR inhibitor nimotuzumab, but here they use nimotuzumab concurrent chemoradiation and compare it with this thing, chemotherapy alone. And here they shown the primary endpoint for this particular study was progression-free survival. And they did show that they were disease-free survival must be. They show that this is a superior combination of chemoradiation, nimotuzumab superior to chemoradiation. But again, here they use 30 milligram per meter square. And these are basically survival curve, progression-free survival. You can see there is wide difference between these two. And this is the overall survival. The point I wanted to highlight here is about this thing, those patients who are not eligible because of comorbidity, other factors. Vijay is not here, but again, probably there was some, these are the criteria which was used by TMH group for the ineligibility of cisplatin. So there may be some point of the argument whether ECOG2 is considered basically ineligible for cisplatin, yes or no. We many times, and I'm sure many of us do use the thing at least in clinical practice. And these are the definitions, various organ dysfunction and this thing I'm not going to. Last study, close to 350 subjects, primary endpoint 2-year DFS, and they have proven that those patients who received docetaxel in the dose of 15 milligram per meter square, that was the dose they used, the outcome was superior compared to radiation alone and complement to the TMH group for this particular study. This was a meta-analysis published about 3 years ago, and this was 6 years ago. And they did not find any significant difference between the weekly and 3 weekly. So to conclude, available evidence does suggest the chemoradiation is the standard of the care for the head and neck cancer, where you have either the high-risk post-operative setting or definitive setting. Weekly and 3 weekly, in my opinion, if you are using 40 milligram per meter as well, there is absolutely no difference. We have shown data that the weekly protocol probably is better tolerated. And for the subjects who are not eligible for cisplatin, whatsoever the reason may be, options, we have the chemotherapy, you have the randomized data from the TMH, docetaxel as this radiosensitizer. And you have other 2 agents also of this, it's a nimotuzumab and cetuximab. In McKinsey analysis, which was last published about a year ago, there was unfortunately no comparison because they included the subjects who were enrolled into clinical trial until 2016. There was no comparison between 3 weekly or weekly schedules of cisplatin. So unless we have more data in this thing, in clinical practice, I am more or less convinced and comfortable that probably weekly is as effective as the 3 weekly. This is our AIMS head and neck team. And I would like to thank everyone present available here for patient hearing.
There is a question, sir, I think.
Yeah, sir.
Amish first or chairperson to decide?
Sir, thanks for the discussion, sir. For a cisplatin ineligible patients, if there is no cost constraint, what will be your preferred choice of the agent? Will you prefer cetuximab or nimotuzumab or docetaxel? Are you happy with all the data that is there with the 3 trials, and what will you choose if there is no cost constraint?
Thank you, sir, for asking this question. Even I was going to ask the same question.
So I wish Vijay is here. Come on.
before Amol, before sir answers that question, I just have a comment.
So,
Before sir answers that question.